My topic is Whispers from the Womb, the FGR narrative. The thing is, this topic has been chosen in such a way that when we diagnose a case of FGR, then the baby, though small, but it carries a big risk. Risk in the sense of death of the baby. Baby might die in utero, leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die in utero, leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. Baby might die. We have lot of modalities leading to carries a big of the risk in the sense of dreams, death of the pregnancy. initial visit, we have to reassess the mother at 20 weeks. But if there are 3 or more risk factors, then you have to reassess the mother at 20 weeks. At 20 weeks, you have also you have to assess PAPE, pregnancy associated plasma protein, if less than 0.4 mom, or there is echogenic bowel at 20 weeks, they are more prone to develop IUCR. These mothers has to undergo uterine Doppler, because the classical changes in Doppler first starts at uterine, then it goes down to umbilical artery, then to fetal middle cerebral artery. In umbilical Doppler, at 24 to 20 weeks, if it is normal, if uterine Doppler at 24 to 20 weeks, if it is normal, then we will screen the mother at 32 weeks. But if our uterine Doppler is abnormal at 20 to 24 weeks, we have to monitor the mother more meticulously, starting from 26 to 28 weeks. It may so happen that mother is not suitable for examination or monitoring by symphysiofundal height, like obesity, wherein assessment can be wrong due to polyhydramnios, due to anatomical factors like fibroids. Then take the mother as high risk factors and do serial assessment after 26 to 28 weeks. Now, a mother has been diagnosed as FGR. What are the surveillance modalities we have? Firstly, we have to rely upon clinical assessment. That is the most important thing. Whatever may be the Doppler abnormality, we are the clinician, we have to take the responsibility, and we have to deliver the baby in time. We have to balance the factor in utero hostility versus ex utero survival. If we deliver the baby in an untimely way, then we might deliver a premature baby which might not survive. So in utero hostility versus ex utero survival is very important. After clinical assessment, it comes ultrasound assessment along with Doppler assessment. Now Doppler study can be umbilical artery Doppler study, it can be middle cerebral artery Doppler study, then more advanced Doppler studies like ductus venosus artery studies, aortic isthmus Doppler studies. Next comes biophysical profile and biomarkers. Biomarkers are not that reliable and it is not clinically or practically used. Clinical assessment I have already mentioned. We have to suspect that this patient might have IUGR. So every 2 weeks after 24 weeks of pregnancy, patient has to undergo symphysiofundal height measurement. And that measurement has to be plotted in a customized growth chart. Remember, the growth chart that is available in different parts of country, different parts of the world, it might vary. Because growth potentiality in America or India or other part of the globe might vary. So this customized growth chart considers 4 factors: age factors, patient's weight at booking, ethnic origin, and parity. If these 4 factors are considered and their growth, fetal weight, and weeks is plotted under this chart, we call it customized growth chart. It can also vary in single pregnancy and in twin pregnancy. In single pregnancy, the growth chart will be like this. Any value below 10 percentile will be called IUGR. So it actually excludes so many factors, and if we use this growth chart, there will be nothing called SGA, small baby, small mother. None will be automatically out, because this growth chart will guide you which mother is going to have FGR. This is the growth chart, customized growth chart for twin specific pregnancy. Now coming to ultrasound assessment, basically ultrasound assessment we do fetal biometry. If we get in a disparity of growth by 2 weeks, then we have to think of the IUGR. But single sonographic assessment has no value. Doppler velocimetry, I have already mentioned. There are a lot of arteries or veins also that we address during studies: uterine artery Doppler study, umbilical artery Doppler study, middle cerebral artery study, ductus venosus study. Up to this is commonly done, but after that, umbilical artery vein study, aortic isthmus Doppler study, and cerebral-placental ratio. These all will be very informative in late stage. Sequence of events, I have already told you: uterine artery Doppler study around 20 weeks, then again 26, 28 weeks, umbilical artery Doppler study. In this Doppler study, we actually address three parameters. One, end-diastolic flow, end-diastolic velocity. Second, resistive index or RI, pulsatory index or PI. And then cerebroplacental ratio, one of the very important marker of fetal hypoxia. Last markers, ductus venosus artery study, when the blood flow in umbilical artery is reversed, end diastolic flow is reversed, then we have to address ductus venosus study. And we have to wait up to reversal of the ductus venosus study, then we have to take the decision. Uterine Doppler study, in second trimester, if we perform Doppler study in the uterine artery, then we might get a notch, end-diastolic notch. That is very much suggestive that this mother might develop preeclampsia and then followed by intrauterine growth restriction. And this is very important. If we get a diastolic notch, then we have to start ecosprin or aspirin to stop preeclampsia, because preeclampsia itself is a important factor, risk factors for developing IUCR. If we start ecosprin, we have to give it around 16 weeks so that preeclampsia does not develop, IUCR does not happen. But the thing is, ecosprin is not the treatment of FGR. Ecosprin is not the treatment of FGR, rather we can give it prophylactically to stop preeclampsia. In umbilical artery Doppler, first picture shows this is the normal umbilical artery Doppler flow. Second picture includes increased resistance. If the resistance is increased, but in this picture, end-diastolic velocity is maintained, circle, there is end-diastolic velocity is maintained. In the third picture, there is no diastolic flow. We call it absent end-diastolic flow. So pathology starts from here. Then this diastolic flow is reversed. That means the condition is deteriorating and patient is going towards advanced hypoxia. Ductus venosus studies, when the umbilical artery flow is reversed, then we have to address ductus venosus Doppler study, where we can see absence of A wave in the ductus venosus. It indicates atrial heart failure of the baby, and it is very advanced condition of the hypoxia, and that is the time when the baby should be delivered, otherwise the baby might die. Cerebroplacental ratio, it is very important. It is a composite ratio of PI of middle cerebral artery and umbilical artery. Ratio of middle cerebral artery and PI of umbilical artery. It should be more than 1, but if it is less than 1, that means baby is hypoxic and 11 times higher risk of adverse perinatal outcome. Fetus with brain sparing effect has poorer outcome than non-brain sparing effect. Brain sparing effects means baby is trying to adjust the blood circulation within the body. Baby is trying his heart and soul to save the brain. So there may be certain brain damage if the baby is not delivered in time. Role of biophysical profile, while we are in surveillance, we have to do biophysical profile, and it greatly correlates with the fetal behavior. If baby is having loss of breathing movements, basically in biophysical profile, 5 things are seen: fetal breathing movements, fetal respiration, fetal tone, NST, non-stress test, and amniotic fluid index, among which it correlates if the gross body movements are less, that means baby's pH will be less than 7.2. Loss of tone, that means baby's pH less than 7. And BPP, biophysical profile score, maximum score is 10 by 10, but if it is less than 4, that means baby is having impending death, and baby should be delivered immediately, and it correlates well with the pH of 7.2. Biomarkers, there are a lot of biomarkers available, but it is not practically used. CTG is routinely used to monitor fetal behavior, fetal reactivity, and reassuring fetal ECG. CTG is very important that baby is okay, but it does not give any guarantee. And there are lots of inter and intra-observer variation in normal CTG. That's why normal CTG is not used nowadays. Rather, this CTG has been replaced to CCTG to avoid unnecessary interventions like cesarean section. CCTG is very informative. It is computer generated, and there is no inter or intra-observer variations. And what we find is a short-term variability on CCTG that gives the baby's behavior and pH. In CTG monitoring, we actually see whether it is normal or abnormal. Normal means, okay, baby is reassuring, but if the CTG is abnormal, that means it may be variable deceleration, late deceleration. Coming to pathophysiology, what happens in IUGR, how this Doppler change comes sequentially. So I told you first, the pathophysiology in early stage, placental disease starts. That is the time where pathology actually has started, and it gives us lots of time in early onset FGR up to 4 to 6 weeks time. And during this time, lots of signals comes, lots of message comes if we evaluate the baby properly. Then what happens? Urinary abnormality starts, cerebroplacental ratio becomes less than 5th percentile, and we have to follow up with the umbilical artery Doppler. If the PI more than 95, that means resistance is high. Ultimately, endosteric flow will be first initially reduced, then absent. Absent endosteric flow means it is the early stage of hypoxia. Up to this, endosteric flow is the early stage of hypoxia. Then reversed endosteric flow in umbilical artery, that indicates advanced stage of hypoxia, and it is a serious injury or sometime fetal death might happen. In acute injury, it gives maximum 7 to 10 days time. Maximum 7 to 10 days time after reversal of endosteric velocity. But during that time, we should not be very much reluctant, rather the patient should be under observation. Patient might have to be admitted in the hospital, and she has to undergo ductus venosus study. And if ductus venosus study gives absent A wave, then we have to rely upon the CCTG, computerized CTG. If CCTG variation, short-term variation less than 3 millisecond or biophysical profile less than 4, then CTG deceleration starts. So see, lot of events happens in Doppler study first, then CTG reflection at last. So CTG reflection, whenever we get, it is the advanced stage of hypoxia, it is a late stage of hypoxia, so we have to be very much careful to save the baby. In early onset FGR, efficient recognition is very important. In utero transfer to tertiary care centers should be considered. Patient should be given steroids for lung maturity and magnesium sulfate for neuroprotection. Patient will require multidisciplinary care. Patient should be monitored very meticulously, biophysical profile every 2 weeks. If there is no risk factors, then we can go for Doppler study weekly. If risk factors, then Doppler 2 to 3 times per week. In late onset IUGR, pathology also starts after urinary Doppler, that is by more than 95th percentile, and cerebroplacental ratio less than 5th percentile. After that, we have to see middle cerebral artery pulsatory index. This is the early stage of hypoxia, and in late stage, we have to rely upon the aortic artery, aortic isthmus Doppler study. If it reverses, that means there will be the late stage of hypoxia and CTG abnormality. And it will also give almost 9 weeks time. So time span is there. If we are meticulous, we can take all the signals and we can save the baby. In late onset IUGR, ductus venosus Doppler study is not so informative. Rather, middle cerebral artery PI is very important. If it is less than 5th centile or CPR less than 5th centile, it indicates there will be poorer parental outcome of the baby. Even stillbirth baby can happen. Most importantly, I have told you repeatedly, if Doppler is normal, the baby should be all right, but there is no assurance that fetus is not compromised. So it has fallacies also. Factors for timing of delivery. So before timing of delivery, we have to consider certain factors, presence of risk factors for the mother. If the mother is having any risk factors, then mother has to save first. You have to balance both, but mother is our priority. fetal anatomy should be considered anomalous baby